Hello everyone, I'm Pooja Shah, the operations editor at InsightsCare India. So today we are going to talk about something that has been a harsh reality for millions of Indians for far too long. So let's just imagine your grandfather is fighting for his life. You need an ICU, but the nearest one is 4 hours away. And by the time you get there, it's already too late. This is the reality millions face every day until one doctor said, and he decided that enough is enough. So, as part of our special edition, Healthcare Leadership Excellence, India's top 5 leaders shaping the future. Today, I'm honored to speak with the man changing the face of rural healthcare in India, Dr. Raja Amarnath, the founder and CEO of CIPACA. Dr. Raja, he left his job at a top hospital to build ICU care facilities where no one else dared to go. And in just a few years, we can see that he and his team have saved over 1 lakh lives, and that too at a fraction of the cost of metro hospitals. So, Dr. Raja, it's truly a privilege to have you here today for this conversation. Thank you so much for joining us.
Thank you.
So, moving ahead, we will understand the journey of Dr. Raja from being a medical professional to an entrepreneur. So, can you please give a brief about your journey and what were some of the pivotal movements along the way?
Well, I have graduated from Sri Venkateswara Medical College in Tirupati.
Mhm.
So that's where I did my MBBS. Then I went on to do MD in pulmonary medicine that deals with lungs. Then I pursued my DM super specialty in critical care. Then I also got a fellowship from European, diploma in intensive care. That's called EDIC fellowship from UK. And I also hold FRCP from Edinburg. That's my educational background. And well, about CIPACA, it's our dream project. I would say it's my mission, life ambition to build ICUs as should be accessible and should be affordable to the common man. You know? Like in the introduction, you said just now, you said, currently in the country, at least for 70% of Indians, ICU is not reachable within 2 hours. They have to travel, right? And second thing is ICU cost will be anywhere between 50,000 to 1 lakh a day. So this is where we wanted to do create an impact. So we, along with me, some of my colleagues, doctors and nurses, we teamed up and we created this concept as CIPACA. Okay. In other words, it is like shop in shop ICUs for the small towns and all rural areas where we collaborate with other hospitals and create ICUs there. So far in the last 5 6 years, we could reach out to around 6 states in the country, and we have been operating around 300 plus ICU beds. And every year we manage around 50,000 patients in these, ICUs. In other words, 50,000 lives getting saved. That's the brief introduction about our organization.
So, that's a great start to begin with. If I may ask, what are some specific initiatives or programs at CIPACA that you are particularly proud of?
CIPACA, when you say you want to operate ICUs at a small towns, the first challenge will be about manpower. Everybody says there are no doctors and there are no nurses, right? So, but the reality is there are doctors and nurses, but they don't want to go there. That's the actual gap. Now, why do they? not want to go there is because the moment they go there, no, okay, the man has the skills and he has the will to go there, but he needs the system to be available. No, a platform should be there for people to work there. Correct? Just because one doctor cannot create anything, whereas if he is given the other team of doctors, nurses, proper lab, proper facilities, all these things, then they will go. Also, we need to give them some sort of academic improvement also. So we launched a specific fellowships for both doctors and nurses for ICUs.
Mhm.
That's called, fellowship in intensive care medicine, fellowship in, critical care nursing, and then master's degrees also we have, in collaboration with certain academic organizations, and also in collaboration with, Indian Medical Association. We launched these courses. This is the one very big initiative which has prompted the doctors and nurses to pursue these courses, wherein the bottom line is that you should be ready to are willing to serve in the so-called tier 2 and tier 3 cities. That way you are actually addressing the gap, right? Second thing, we have got an internal inbuilt software called SIA. So the software is about, is otherwise called SIA. SIA means survival improving automation. So in that area, there are groups of doctors who will be involved in managing the patients. So this algorithm and this software, which actually is able to bring the international standards of ICU care to to the even in the tier 3, tier 4 cities, where not tier 2, tier 3 cities, where if you want to serve. Because every single patient is actually seen by different levels of teams. Okay. It's not just ICU doctor and ICU nurse. There will be infection control teams. There will be clinical pharmacy teams. There will be senior ICU specialists. There will be multidisciplinary ICU care team. So your quality of care for the patient will not be different from a city level hospital versus a small hospital. That's the second initiative we did. And the third one is we don't restrict ourselves to the ICU alone in that area. We go into the community, right? Because when a patient gets into an emergency at home, say in a village or in a periphery of a small town, by the time they call the ambulance and the ambulance comes, you are losing around 20-30 minutes time. No?
True.
So how do we ensure that even this time this can be made up, something can be done during this time. So that time you cannot be there everywhere. No? So if you can manage to train some of the youth, some of the villagers, some of the citizens of the town population, whoever is interested. So on the community-based emergency care, so they know compared to common man, they know if they see a person who is electrocuted and then he got electric shock and he fell down, so what to do at that point of time? Someone became suddenly unconscious, what to do? Someone got hit by a vehicle and is bleeding, what to do? Someone is wheezing, what to do? Someone is getting a burns, what to do? Someone consumed poison, immediately what to do? See, there are several emergencies that day in and day out people face. Other than calling the ambulance, what else can you do at that point of time, right? If you can train people and that person happened to be there at that place, and then he can do something better than just calling an ambulance. So that course we named it as CIPACA Friend. It's nothing but community-based emergency care training for people. So that way, these are some of the initiatives I would like to share, happily that which are actually creating an impact. Because ultimately, it is the time that you cannot get it back. Correct? Life, when it depends on time, if you save that time, you will save that life. Anything and everything can be earned later, but this cannot be earned again. No? So that is the reason why we wanted to create that impact in those areas, and we are doing this. initiatives.
Thank you, Dr. Raja, for sharing that. Those initiatives really show how innovation and learnings can transform lives, especially during that point of time, the gap when the ambulance arrives. So now, what are the major challenges you faced when you set up an ICU in rural area and compared to a metro city?
See, our model, the overall, the final objective of the model is to make the ICU care affordable, for accessible and affordable.
Mhm.
To make it affordable, you should not be reinventing the wheel, right? Suppose if we have to go to that tier three town where we also have to buy a land, then build a building, buy all the equipment, then eventually the cost will be the same, right? You ultimately the to for you to get the return on investment, you have to charge than the customer. No? Here the customer is patient. So to do that, what we did was we went into the shop in shop model. So that if already there is a hospital built where that man doesn't have an ICU, he is referring out patients already. So if you set up ICU inside that hospital, it is a win-win situation for both the hospital and the CIPACA, right? So there is one inherent problem in this model is that the the mentality of the partnering hospital owner. If he has got that vision that okay, I also have to invest something on this, right? I also have to wait on this. So that is where we have to actually go down to the level of teaching them the basic essentials of business. Because unfortunately, doctors, they were never trained in business. During his entire course of medicine, super specialty, everywhere, they are trained only in managing patients. But ultimately, they end up becoming hospital owners, right? Banks give them loans, left, right, center. So they start hospitals, but they don't know how to operate in the way that the city corporate hospitals are operating. So what will happen? They end up spending unnecessary money on those areas where actually the return is less. So when you go there as an ICU, when we go there, we have to actually train them, teach them, educate them, on the basic essentials of business, and so that they keep these resources for the ICU development. That is one hurdle for us. So the second thing is, of course, manpower. So essentially, you need doctors and nurses to operate ICUs over there. No, we are not operating tele ICUs where it's very easy for me. I set up some video conferencing systems over there, some cameras over there, and then from sitting here, I can give what to do, the instructions I can give. But that doesn't make an ICU. No? Can't make an ICU like that. So here we are operating real ICUs. So to operate a real ICU, you need to have manpower. So how can I get the manpower where the doctors and nurses should be willing to go there and should be willing to work in the constrained resource settings. The resources are not very plenty there, correct? They are limited resource settings. They have to be in the village or a small town, and they have to work with the limited resource settings. And most importantly, you cannot pay them exuberantly because you are not anyhow charging on the patient so much compared to city. You are actually charging one fourth on the patients, correct? But you can't say compared to city, I'll give one fourth salaries. No? To the doctors and nurses, no one will go there. So to actually address that gap and then finally getting the ball rolling is a challenge, of course, we have taken up. Successfully we have been doing. But this is our challenges we faced, but we successfully came out with our own solutions for the business.
It's more like an eye-opening to hear about the different hurdles that rural healthcare face. And speaking of which, What is the difference between the patient profile when you see a rural areas and compare it to metro city? It can be, for example, diagnosis method or facilities available in rural area.
The patients, there is a, if you ask me, at least a 50% of cases, the profiles are entirely different between rural and city, hospitals, the patient profiles. The common patients that come to rural hospitals, small hospitals, taluk level hospitals are mostly like, common infections, seasonal infections, and snake bite, poisoning, simple road traffic accidents, you know, and then the complications of surgeries, regular surgeries, and then organ failures like diabetic complications, and then kidney failure, heart failure, asthma, COPD, and then respiratory failure. These are the things. We don't usually, naturally, we don't manage complex surgeries or, multi-organ failures or transplant patients like that. They don't constitute more than 10% of ICU demographic profile. So, but being managing a tertiary level ICU at a taluk level, you can actually address 90% of the ICU problems. It is the same ICU problems which in cities they end up paying 4 times more money. The city hospitals are like corporate hospitals are like five-star hotels, correct? Even if you go for a cup of coffee, you have to pay some 500, 600. No, the same. For example, a plate of idli or a plate of roti will cost you 1,000 to 1,500 rupees there. Same thing in a small, simple restaurant, which will be hotly served very hot and sometimes equal taste. Okay.
Yes.
And you can actually get it for maybe 100, 200 rupees. Now, you can go to a five-star hotel if you really want to have a big buffet or, celebrate something or a big, you know, a very exotic dish is fine, completely justified. But imagine everybody is going for a dosa or a roti every single time to a five-star hotel. Is it not burden on them? It's the same difference here. So we are catering to common people with common problems in ICU, which constitutes around 80 to 90%. If these people, especially when they are managed within, when they are reaching to the ICU within 30 to 40 minutes time, because a taluk, if you take any village in and around 20 kilometers area, can reach the taluk within 30 minutes, right?
Yes.
Maximum is 40, 45 minutes. Now you still are within the golden hour, and the ICU right now can manage well. Imagine the same city level ICU is there now. In the previous situation where the ICU is not there, probably the patient will come to the hospital, knock at the door, doctor will analyze and then says, I'm sorry, I can't manage. Then that patient has to travel again. You see the pathetic situation in the areas where there are no ICUs. Now, patient doesn't know whether I should go here or there. Half of them will say, okay, let me go there. Let's take 2 hours and go. Some of them will first come to the hospital thinking that there can be something can be done. Now, the doctor, of course, he may do some first aid. Is this ultimately, sorry, I can't manage you. Then, after spending 1 to 1.5 hours, then they start from there and go to other place. 4 5 hours time before you actually get the proper treatment. Now, you have the ICU already ready there, right? Now, in half an hour's time to 45 minutes, time patient came and exactly the treatment that is supposed to be given at a city hospital with exactly the same international standards of care if the care is delivered. Now look at the, the possibility of the growth, possibility of improvement, the possibility of recovery of the patient. That is the reason why our recovery rates or survival rates are more than 90% in our ICUs. So it's the difference. If you ask me, profile is different. and the time taken to initiate the treatment is different, and the recovery rates are different, survival rates are different.
Thank you for highlighting that. So, as a leader, what core values do you prioritize within your team at CIPACA?
Yes, when we built this organization, we decided one core value for all our team members. It is like, let us work like a family, and let us treat the patient also as a family member. That's our core value. So we celebrate, we get together, the way we take care of each other, everything we depend on a family culture. And then every employee in the organization is given choice to contribute to the growth of the organization. For example, my team members, they don't uh, hesitate to talk to me, even to tell me that you are wrong. I appreciate them. For example, they can come and tell me, say clearly saying that, sir, for the vision that we are thinking, I think this method, whatever you are thinking, is not correct. Let us do this method. Then we sit down and we brainstorm, and then we finalize the method and do. So as far as decision making is concerned, we do a democratic decision making. But when it comes to execution, this is an ICU, and ICU is a war zone. So the execution is usually like a military style execution, no questions asked. Once we create a structure, we follow it. But until a structure is created, we debate, we fight, we argue, and then we create a structure. The same scenario culture percolates at the lower levels also. Even at the ICU level, they'll have regular meetings, and then the in charge nurse, in charge doctor, admin in charges, they all sit down and discuss and say, okay, to improve the ICU quality of care, let us do something like this. So that is how what we believe is an inclusive growth, and every employee is a partner in the organization. As far as the vision and mission is concerned, they all share the vision of the organization. That from the beginning itself, we have been very, very clear. In fact, the organization's process is such that only those employees who align with this will actually stay long term. Those who are not, naturally they cannot be in this system. They usually after a few months they say, sorry, I cannot adjust in this system, and they go. So the as I said, the every single employee should share the vision and mission of the organization from the beginning itself. And then they are part of it.
Values clearly builds a very strong foundation for your team. So, moving ahead, what makes CIPACA a trustworthy company and it's worth investing in?
Well, there are two, three things people have to think of. If you're talking about an investor who wants to, invest his money into a company, what are the things he would think of? When you say trustworthiness, right? It should be the track record. No? First of all, if somebody is performing or not, that's one thing. And before that, it begins with the vision and mission of the organization. Sipaka is not trying to do something, offering something at a premium value, competing. Like it's not a already existing laptop. I'm giving MacBook to you. Not like that. Correct? No. We are going to a place where there is nobody. We are filling the gaps. Right now, we are not competing. We are filling the gaps there. Correct? So the organization's vision is about creating a social impact. That's number one. Making a life-saving care accessible and affordable. Number two. The third thing is the positioning of the organization in a space where it is still, the ocean is still blue. It's not a red ocean where, people are fighting with each other for customers, trying to kill each other, right? We are going and fulfilling somewhere. Third thing. Fourth thing, okay, everything is fine on paper. but are we performing? A track record of 1 lakh patients, right? And then customer feedbacks about the hospitals, even the partnering hospital who is growing. Not that you go to a hospital where you do your own business, but every single partner of our, ICU who is in a hospital owner, they double their turnovers within 2, 3 years time. It's about their sustenance for the 2, 3 years is that what matters, right? So which means the partners are happy, the customers are happy, the vision is correct, the area, the domain or the business geography of the business is clear. Okay. Only thing is investors should not think this organization or this business model comparing with in a corporate hospital or any other um, digital business model where there people may talk about any big numbers, fast growth, things like that. Alpaca is like an elephant. It grows very, very slowly, but it is massive. You can't compare this with a rabbit. It goes faster and it
Okay.
runs
Yeah.
faster. Runs faster. I tell this to my people. It is like they say Airavat, white elephant. Alpaca is big. No, it's massive. The people with big vision, massive vision, a long-term vision, only they will align with CIPACA. If you have a short-term goal, probably CIPACA will not align, right? Fundamentally, it's only one thing: healthcare. Healthcare, until humanity is there, it's going to be a greenfield business. It will never have any problem. Healthcare. Now, in healthcare ICU, everybody you know who is living right now, birth has to die one day. It is said that every single person, either you or me or anybody, one day we have to go through ICU, one point of time, right? So that way, what more is there to define the need of the business? And more than that, if you are an OPD doctor, you are seeing patients, general patients like that, like they say diabetes or endocrinology, neurology, nephrology, cardiology. You can have Ayurveda, homeopathy, Ayush doctors may come into picture. For ICU, who will come into picture, right? So even the other disciplines cannot enter. It's a extremely niche area. That is why it takes time for people to understand, of course. And second thing, as I said, it's a huge business, massive business. So if investors have that vision in mind, only to them it appeals.
Yes. So, what system does CIPACA have to ensure successful operations independent of top management?
I just now explained one system is that inclusive
Yes.
operations, so that everybody is empowered at every single level. So systematic empowerment of people. For example, there is an ICU at one place. CIPACA is very simple, no number of ICUs, right? Each hospital there is one ICU. ICU will have leadership at every single level. Nurses, admin people, doctors, right? They are empowered. So when patients come to how to manage, how to interact with the consultants, how to interact with the partnering hospital owners, and then auditing of patients, quality care, everything is empowered there. The next level, cluster level or regional level teams will only check the quality indicators and then they intervene. But day-to-day operations, no one needs to intervene, right? So as a top management, for example, take me, I don't get involved in day-to-day operations of ICUs. There are 3, 4 levels of management. There is cluster level, there is regional level, like that, who will be looking at the dashboards of quality indicators. Whereas to manage each patient, that happens at the ICU level itself. I don't need to tell them through my mobile or through my video how to manage a patient. But what we monitor is only the supporting them with manpowers and then
Mhm.
testing their quality indicators, whether they are managing properly or not, whether the team dynamic, because a part of the team, a team member in a team will not know what the team is doing, right? He's under the team. Somebody has to see as a bird's eye view from above the team how the team is performing, right?
Correct.
So let them do their own job. But as a team, whether the teamwork is integrated or not, the next level, higher level person will see, right? Then they give the PDCA cycle, people say, oh,
Mhm.
PDCA, plan, do, check, act. So planning and doing will be happening. Checking and acting will be happening at the higher level. That is how it happens.
And if you could share with us a few achievements that you have made related to patient and also organization.
Well, there is one big achievement I would like to say that every single patient who comes to CIPACA and is managed and saved, right? If that ICU had not been there, either he would have died or he would have had to go to a city hospital where he would have had to spend around 4 5 lakhs extra. That way, a 1 lakh patients managed is equal to 1 lakh multiplied by 5 lakhs of saving on that rural areas. That's the massive amount that we saved for rural economies. Correct? Sometimes what happens, for us, most of the city dwellers, for us 10 lakhs is not a big deal. For a person who lives in a taluk area or in a village area, 10 lakhs is his life savings, lifetime savings. Correct? Yeah, they have to sell their house, they have to sell their jewelry. Because of that, one generation will be gone. I would have, as a family man, he would have kept that 10 lakhs or 15 lakhs for the studies of his son or daughter or for the marriage, right? That's gone, no? It takes for them one generation to recover. So if someone is actually measuring that good virtue, you know, that that comes out of this, that is the biggest, if you ask me, biggest achievement that CIPAC has made. Of course, other than that, there are several awards and accolades, we received from several organizations. Say, for example, the best rural ICU service provider at a national level, most innovative, ICU, innovative healthcare delivery organization, and then most socially responsible organization, things like that. These are all the things that, the recognitions that we happily, of course, they are there for us to showcase. But what I cannot showcase is what I said just now, the impact on rural lives, the people lives, for middle class people is what actually CIPACA is proud of.
Yes. And the milestone of creating that impact is in itself very incredible and also truly a testament to Sipaka's vision and hard work that you have been carrying along since so many years. So, what advice would you give to aspiring medical professionals who wish to make a difference in critical care?
Good question. There are, currently um, there are around 1 lakh MBBS doctors coming out every year, in the country from our own Indian-based private and government medical colleges, as well as those who are coming from called as, foreign medical graduates, right, from Philippines, some of the countries inside that, in and around Russia, China, all these areas. Whereas in the country, there are only 30 to 40,000 postgraduate seats, which means every year you have 50,000 MBBS doctors left without PG seats. We all know that MBBS is not enough, correct? You have to get into MD or MS. You have to become a postgraduate person to get into a better, profession or a better settlement. Now, choosing to get into ICU, ICU care or critical care as a specialty, okay, and especially the rural ICU care as a specialty, because there is a difference between a simple difference is that in city critical care everything is available, right? You just go there, ask, that comes. In rural ICU care or a small town ICU care, where you will not get everything at handy. You need to do little bit of extra work there. But if you get trained in that, you can really excel like anything because there the patients are only there in rural areas. These are the people who are going to cities because it is not there. But if you really go to a small place like a taluk area and settle down there, especially in ICU, that's a very good golden opportunity for people for to build their career. So I would say both to the doctors and nurses to pursue ICU care as a specialty for their, to build their career and to go to the small towns and rural areas to settle down. So that way they can actually give the fulfillment of their study, their career, both economically and also, morally, ethically, financially, in every aspect.
That was such a great advice. Moving ahead, the last question from my end is, what are your future plans and vision for CIPACA?
CIPACA's long-term vision is to provide ICU care accessible and affordable to every single Indian. To do that, you have to have one very good quality ICU at every taluk. India has 28 states, around 800 plus districts, and 5,000 plus taluks. Taluk is a fundamental area, right? Surrounded by some 20, 30 villages. Taluk will have around 40, 50,000 population, the taluk headquarters, and surrounding places together. It constitutes 1 to 2 lakh population. If you can give one ICU to that population, they all can reach to that ICU within 30 minutes time. So you will be able to save every single life, there, number one, whichever is possible. The second thing is they all can save so much of money because they can get it here itself with one-fourth cost. So CIPACA wants to go and set up ICUs at every single taluk in the country. That's the long-term vision for CIPACA. So in that direction, we are moving forward. Of course, we definitely need fund investors to do this work. So based on the collaborations available, based on the supports available, we keep moving forward. But wherever we are not there, you can take it granted that at every taluk, at least one life is lost per day because of lack of such high quality life saving services in their accessible range. See, that is the problem currently it's going on right now. So we want to do it as soon as possible, but of course we need support, from different people for organizations, to do this as soon as possible.
So I am done with my questions, but is there anything that has been missed and you wish to add something to it? So it was really a great conversation, and thank you, Dr. Raja Amarnath, for sharing with us your incredible journey and insights. Through this interview, it's very clear that your dedication to transforming rural healthcare is truly inspiring. And we are grateful for the work CIPACA is doing to save lives across India. So, on behalf of the entire team of Insights Care India, I wish you and your team continued success and growth ahead.
Thank you so much for the opportunity.